Okay, first I would like to thank Mr. Chair, and I would like to thank the organizing committee for inviting me. My talk is something different from IBD. I will talk about endoscopic management of obesity for gastroenterologists. As we all know, obesity is not just a problem, it is a serious disease that requires a teamwork of gastroenterologists, endocrinologists, psychotherapists, physiotherapists, because it requires intense and serious treatment. By definition, obesity is a chronic, lifelong, multifactorial disease of excessive fat storage that may impair our health. Worldwide, obesity had more than doubled since 1980s, with more than 1.9 billion adults are overweight and more than 600 million were obese. More than 42 million children less than 5 years old are overweight or obese, and as you all know, obesity can kill more than underweight. But the good thing is that it is a preventable disease. As regard to the prevalence of females, adult females worldwide as of 2014, as you see on the map, the Middle East where I came from and in America, more than 30% of our adult female population were obese. In Europe, it's about 20 to 30%. As regards to males, the incidence have decreased a bit in the Middle East to be 20 to 30% of our adult males who are obese, but still high in America. Obesity can lead to more than 160 diseases with 15 in the GI. That's why every gastroenterologist should take care of obese patients. And these diseases including hypertension, diabetes mellitus, dyslipidemia, coronary artery disease, stroke, sleep apnea, osteoarthritis, gallbladder disease, GERD, NAFLD, and some cancers. And the cancer risk can increase by just 13 kilograms above my normal body weight, including cancer of the uterus and the cervix, endometrium, the ovaries, breast. For the GI, colon and rectal cancer increase in the obese patients, esophageal cancer, liver and gallbladder and pancreas, kidney and prostate. And 2.5 million can die each year from obesity or other obesity-related diseases. And the good thing is that if I can lose or sustain 5% of my excess weight, I can prevent or reduce this risk. And this is published by the NIH in 1998 as a guidelines for the management of obesity. When you search in the literature or any book for obesity management, you will find it is divided in 3 categories up to date: lifestyle modification, medical treatment, surgical treatment. Lifestyle modification, only modest weight loss and the patient regain the weight again. Pharmacotherapy or medical treatment, we have 5 approved drugs by the FDA. The last 2 are the Contrav and Saxenda, which were approved in late 2014. But they only offer 3 to 9% weight loss, but they have a long list of side effects and long list of contraindications. As bariatric surgery, it is the most effective and durable. We have 3 operations done nowadays, the most common of which is the sleeve gastrectomy, the Roux-en-Y gastric bypass, and the lap band. But less than 1% of those eligible for bariatric surgery will do bariatric surgery. This is because the fear of complication. What's published is it's 17% morbidity in expert centers, fear of mortality, although mortality is comparable to lap chole, so it's a bit safe, and the fear of cost, not all insurance companies cover bariatric surgery. So we have a gap that we need to fulfill in a non-invasive, durable, effective way without the need for surgical or medical interference. A very nice article was published in the Endoscopic Journal a couple of months ago about, are we ready yet? Are endoscopists ready yet to face this epidemic? And the answer was yes, as obesity is a global epidemic, and at the global level, the future is bright for endoscopists. So endoscopic bariatric therapy, or EBTs, can be divided into gastric and small bowel, as in bariatric surgery. Gastric, mostly restrictive, and the small bowel, mostly malabsorptive. Indications for EBTs as a primary treatment for obesity, to treat metabolic disease, as a bridge to surgical therapy for especially for super obese patients, those with a BMI above 60, in order to decrease the anesthesia risk, to decrease the pre and post-op complication, and also as the management of failed surgical bariatric procedure. And there is also a very nice article published in the Gastrointestinal Endoscopy Journal last May about endoscopy in post-op pediatric patients. The ASGE, the American Society of GI Endoscopy, and the American Society of Metabolic and Pediatric Surgery has set a threshold for safety and efficacy for all EBTs, and they set a 25% excess weight loss measured at 12 months in order for a new device to be approved. And the difference should be between the primary and the control should be less than at least 15, and the side effect or the serious adverse events should be less than 5%. I will start by the gastric interventions, and so far I will talk about 8 devices. Gastric restriction induced early satiety. It's thought to increase the stimulation of gastric mechanical and chemical receptors, alters gastric emptying, and modulate the level of gastric or oxygenic hormones. The first device I'm going to talk about is the intragastric balloon. It's very old now. It's been there since 1985, and the idea came from the use of gastric bezoar in 1982. Garen and Edward were gastroenterologists in America. The Garen-Edward gastric bubble were first approved in 1985, but 3 years later it was disapproved because it has lack of efficacy and a long list of side effects. Most balloons I'm going to talk about are inserted and removed by endoscopy, and they can prevent or reduce cardiovascular and other obesity-related diseases. Up till now, we have more than 17 different balloons. As you see from here, we have balloons we can inflate with air. We have balloons that can be inflated with saline. We have both. You can, like the Indalis balloon, the French one, we can inflate with saline and air. The last 2 balloons, you can ingest the balloon without endoscopy. The position is confirmed by fluoroscopy, and then the balloon disintegrates by itself. So the last 2 balloons, they have no any endoscopic interference. The first balloon I'm going to talk about is the Orbera balloon. That's what I have been using in Egypt. It is there since 1992, and it is a spherical balloon made of silicon filled with 400 to 700 ml saline plus 10 millimeter methylene blue as a color indicator in case the balloon ruptured. The methylene blue is systemically absorbed. There was a patient noted that the balloon has deflated, and he came and we change the balloon for him. The deflated balloon comes preloaded on a catheter, which is spinally advanced transorally into the stomach. The balloon is durable for 6 months, and then it is retrieved by endoscopy. This balloon, early in this month, was approved by the FDA in August 6, 2015. I will show you a video here for insertion of the balloon. After the patient came fasting for 8 hours under conscious sedation, we insert the scope first before inserting the balloon to see any contraindication as hiatus hernia more than 5 centimeters, as peptic ulcer, as bleeding lesion. Also, pregnancy and lactation are contraindications. The use of non-steroidal or anticoagulation, not medically supervised, are also contraindication. We start to inflate the balloon with saline plus methylene blue. The procedure takes about 10 minutes. The patient stays for the hospital for 1 hour, and then he can go home and start his daily activities. Six months later, after he lost his weight, the patient came, but this time he fasted 24 hours on liquid diet because the balloon caused delayed gastric emptying, then 8 hours complete fast. We insert the scope to check if there is any food residue. We have to remove all food residue before we start to remove the balloon. Then we puncture the balloon and start sucking all the saline and methylene blue outside. And then, using a balloon grasper, we hold the balloon. This procedure takes about also 10 minutes. The patient stays in the hospital for 1 hour, and then he can go home, start his daily activity. The results, 10 prospective trials, including 1161 patients, had showed that excess weight loss ranged from 11 to 51 at 12 months. A meta-analysis including 30 studies, 18 prospective and 12 retrospective, on 4,877 patients, weight loss ranged from 17 to 28 kilograms at 6 months. Another 3 prospective studies evaluated the efficacy of sequential use versus single use, showed that 4 PMI points decrease after 2 sequential treatment, like for 1 year. The last 2 studies reported long-term data after implementation after 36 months showed that only 6% of the patients maintained their total body weight loss. The effect on comorbidities, as you see here, very nice response or very nice decrease in all comorbidities like metabolic syndrome, hypertension, dyslipidemia, diabetes, obstructive sleep apnea syndrome, almost 0. So in general, it can resolve about 52 to 100% of comorbidities. As regard to safety, the only complication we have that in the first week after implementation of the balloon, we have pain and nausea. 18% have GERD, erosions 12%, early removal about 7% from intolerance and from severe vomiting. Perforation and death rate is 0.1 or 0.08%, so it's very safe. And this was done a meta-analysis on 8,500 patients. We do a study on the Egyptian population on 448 patients. 2 of the patients have prematurely deflated the balloon. 12 patients removed the balloon for severe intolerance or other problems. 14 patients lost for follow-up, so we have 420 patients. 71% of our patients lost more than 25% of their excess body weight. 28% lost less than 25%. 1%, which about 4 patients, have no weight change. When we compare both groups, those who lost more than 25% and those who lost less than 25%, we found that those with a BMI, high BMI, above 40, have low excess weight loss as compared to those with from 30 to 40. The second balloon I'm going to talk about is the reshaped U balloon or dumbbell-shaped balloon. This is composed of 2 balloons connected to each other by independent channel. We inflate every balloon with 450 saline, so it's a total of 900 ml. Also, these balloons removed by endoscopy after 6 months, and it is FDA approved on July the 29th, 2015. European study done on 21 patients, randomized to the reshaped balloon and 9 to lifestyle, showed that 31.8 excess weight loss at 6 months compared to 18.3 for lifestyle group, and at 12 months, 64% maintained their body weight. The reduced pivotal trial, which was done before the FDA approval, showed that 25% excess weight loss at 6 months as compared to the other group. Here they divided both groups. One group to DU balloon plus diet and exercise, the other to sham endoscopy plus diet and exercise. So the patient had endoscopy, he doesn't know if he had the balloon or no, and the effect was quite very significant. The third balloon I'm going to talk about is the SPADS balloon. This is the only balloon approved for 1 year implementation, and this is adjustable balloon. You can either decrease the fill volume to improve tolerance of the patient or increase the full volume to enhance efficacy. And it's made of silicone with extractable inflation tube for volume adjustment. The fourth balloon is the O balloon. This came packaged within a large gelatin capsule. The patient ingests the balloon with water. Position is confirmed by fluoroscopy. Then we start to inflate the balloon using 250 ml nitrogen gas. The patient can swallow 1 balloon or 3 balloons either at the same time or on 3 months. Then the 3 balloon can be removed after 3 months. The second device I'm going to talk about for obesity management is the transbyloric shuttle. And this is composed of 2 spherical bulbs. A large one prevents migration from the stomach, and the smaller bulb And this requires an overtube for insertion, and the device is self-assembled while inside the stomach. It creates an intermittent seal to intend to delay the gastric emptying and induce early and prolonged satiety. A study was done of 20 patients, and it was published on the official journal of the American Society of Metabolic and Bariatric Surgery, had showed that at 3 months and 6 months, patient can lose 14 or 25 plus or minus 14 to 41 plus or minus 21 of their excess weight loss, which is quite significant. The third device is a full sense device. This is a modified, fully covered gastroesophageal stent with a gastric disc, and it's connected by struts. It is deployed and removed by endoscopy. Once deployed, the gastric disc applies a pressure on the gastric cardia to induce satiety. The fourth device is the aspiration therapy. It's very similar to the gastrostomy tube. The third of the meal, 20 minutes after eating the meal, can be removed via the gastrostomy tube. The device came. You can connect the device to the gastrostomy tube and start by a siphon effect to remove 1/3 of the meal. And this process takes about 5 to 10 minutes. And at 2 years follow-up, it showed that 55% excess weight loss, which is quite very significant also. But not all the patients like this device because it is time-consuming, and not all the patients like to have a hole in their stomach. The fifth, and actually it's not a device, it is a suturing system, very similar but not identical to the lap sleeve gastrectomy. We start suturing the stomach from inside all the way, transmural sutures all the way from the GE junction to the antrum by using an FDA-approved endoscopy suturing device. And this process requires a double-channel therapeutic endoscope aided by a tissue helix device. And this is a device. 2 studies have evaluating the endoscopic sleeve gastroplasty on 20 and 10 patients showed that 30 to 40% excess weight loss at 6 months, which is comparable to the lap band. The 6th device is the primary obesity surgery endoluminal or POS. A lot of cases have been done here in Barcelona, in Tecnon. This requires the insertion of a transmural anchors, 8 in the fundus to reduce accommodation, and 3 in the distal body to delay the gastric emptying. But it requires an overtube style platform with 4 working channels, 1 for the slim endoscope, 7mm endoscope, and 3 instruments, the G-Prox as an endoscopic grasper, the G-Lix as a tissue grasper, and the G-Cath as an anchor delivery system. A single center open label prospective trial enrolling 45 patients had showed that 49% excess weight loss at 6 months. And here the device. I don't have a pointer here. Okay. This is a device with the 4 working channel, and this is the instruments. The 7th device is very similar to the previous one, is the articulating circular stapler. It is composed of a head plastic ring with titanium staples, and it also applicate like 8 staples in the fundus and 2 in the antrum. A Dutch study of 17 patients with a median BMI of 40 per meter square have showed that 35.9 excess weight loss at 12 months, which is quite significant. And here is the device, and this is the ring. The last one in the stomach is the intragastric injection of botulinum toxin A. Botulinum toxin, as you all know, it inhibits acetylcholine release at the neuromuscular junction, and it causes delayed gastric emptying, reduced gastric accommodation, and this induces early satiety. But it required multiple injections, like 10, more than 10, in the fundus and in the antrum. A recent meta-analysis of 8 studies revealed a statistically significant efficacy for weight loss. But repeated treatment are needed as the duration of action is about 3 to 6 months. And it can be used before bariatric surgery to decrease the risk of post-op complication. Small bowel interventions. The proximal small bowel is efficient in nutrient absorption, and it plays a major role in glucose homeostasis. Enteroendocrine cells sense luminal nutrients and release gut peptides that are sought to mediate satiety and enhance insulin secretion. Bypassing of the proximal small bowel may contribute to weight loss and diabetes control. The first one I'm going to talk about is the endobarrier, or the duodenojejunal bypass sleeve. It is about 60 to 65 impermeable sleeve of Teflon that is introduced by endoscopy over a stiff wire, and it requires fluoroscopy, under control fluoroscopy, to detect the position of the jejunum. Then it is removed after 12 months, and it causes a membrane between the duodenal mucosa and the food. So no food is absorbed. And here is the membrane, Teflon membrane, and here is the ring that is to hold it in the bowel and prevent migration. Seven studies have showed that excess weight loss ranged from 12% to 47% at 52 weeks. For diabetes, 3 randomized controlled trials demonstrated decrease in hemoglobin A1C from 0.9 to 1.7 over that seen in the control group, which is quite very good. And it is used in many European countries as a metabolic device now. As regard to safety, a study done on 272 patients have showed that pain up to 60% of the patient, early removal 18%, which is quite high, migration 4%. They have one case of esophageal perforation during retrieval of the device by endoscopy, cholangitis and acute cholecystitis, liver abscess 0.1%. So this device needs some modification in order to decrease the risk of side effects. A very similar device called the Valentex, or the gastroduodenal bypass sleeve. It is 120 centimeters long, and it is fixed at the GE junction by both endoscopy and laparoscopy. So it excludes the stomach and duodenum and proximal jejunum. It mimics the anatomical changes of round 1 gastric bypass. And a fully endoscopically deployed version of this device is in development. The third thing I'm going to talk about on the small bowel is thermal ablation using radiofrequency by duodenal mucosal resurfacing procedure. They hypothetically reset the duodenal enteroendocrine cells that have become diseased, and this restores the signal that can improve diabetes control in normal weight or obese patients. The last one for the small bowel is the use of magnets in endoscopy. The use of magnet in endoscopy have been there since 1980s, and they use the magnet for removal of foreign body ingested in the esophagus or in the stomach. Now, a lot of papers are talking about the use of magnet in GI endoscopy to create incisionless magnetic compression anastomosis as gastrojejunostomies, gastroliostomies, and duodenoliostomies to induce an ileal brake phenomenon. This can decrease the food intake and improve diabetes control. Other EBTs that require further studies, like the EndoKinch, the Restore, the Toga system have been stopped now, the TRIM, the StomaFix. These all induce weight loss and very significant weight loss, but require further modifications in order to decrease the side effect list. So we should wake up as obesity is the disease. Endoscopy may offer a solution. Endoscopy may cure diabetes, and that was said by Jack DeVere in 2011 in Stockholm. So in conclusion, EBTs hold the promise of providing the next major breakthrough in the management of obesity. Currently investigated devices have established promising outcomes. It will not be effective without supportive lifestyle therapy. Further studies will help define their optimal role. And always remember, it is not a magic solution, it is just a tool. Thank you.
Thank you very much.
Thank you.
Are there any questions?
Thank you, Dr. Mohamed, for this very nice show. I want to ask you, if you have a patient and have the availability of this procedure of balloon, which one you can advise him? This is the first question.
Actually, I will use so far the Orbera balloon as it's the least side effects.
The least side
And the
effect.
safest, and they have been there since about 25 years now.
I agree with you. And second question, if the patient have a symptoms after he puts the balloon by endoscope, and he cannot tolerate it, can he repeat it or no?
Actually, the answer is depends on the situation and depends on the severity of pain and vomiting. Like I have some patients cannot tolerate pain and vomiting, and they came in the hospital. I admit them in the hospital and start giving them fluids, IV antiemetics and IV antispasmodics. After 2 days, they have complete relief and they go home with the balloon without removing the balloon.
You don't hurry to remove the balloon.
No. So it depends on the doctor-patient
agree with you.
relationship. It's a doctor-patient
don't
relationship.
hurry to remove the balloon.
No, never.
This is the advice we tell you. We don't advise to hurry in the removal.
Yeah.
Thank you.
You're welcome.
I also have one question, if I may. So one of the the side effects of using bariatric surgery, the beneficial side effects, is the loss of appetite, especially loss of fat preference, I guess. Do you also see that when you treat your patients using intragastric balloons?
Yeah, this is also temporary during the balloon, yeah. But after removing the balloon now, so the patient have to be strictly on a diet and exercise program all his life because, you know, obesity is a chronic disease. And now they are talking after Roux and White gastric bypass, weight can regain again. Like we don't have a permanent procedure for obesity. Even in the sleeve gastrectomy or the Roux and Y or the lap band, all have a patient can regain his weight again.
Has anyone investigated the possibility of using something like the transpyloric shuttle for removal of an esophageal food bolus? Could you slide it past the bolus and then inflate the balloon and withdraw the bolus?
Is it for foreign body removal?
Yes.
We can make for foreign body. Why don't you use a snare?
In my experience, it's difficult for some types of food boluses to grab it and pull it out. And I've watched an endoscopist take it molecule by molecule over a course of sometimes an hour and a half or 2 hours to get out a piece of, say, chicken from the esophagus. This seems like a simple thing to do. If you could pass it past the bolus, inflate the shuttle or the device, and then pull the whole thing out, just like vascular surgeons do.
Actually, we do this in ERCP, in removing stones or removing mud in the biliary system. But in the esophagus, we don't use this. We use the piecemeal cut. If I cannot hold it with a snare, I can cut it into pieces. And yes, it takes a lot of time. And it's a very good idea to have a balloon to remove it from the esophagus, but the patient have to be intubated.
Yes,
because
we do
if I remove it like this, it can go in the trachea.
Right. That's what we do.
Yeah.
Okay, thank you.
Thank you.
Thank you for your nice talk. 2 questions. What is your current approach for the patients that after one gastric balloon insertion, you said you prefer the 6 months one, they have not a very well decrease in their weight, or they gain weight after. What's your preferred approach? Do you reinsert another balloon, or you are going to another technique?
Actually, depends on the patient. If he has lost weight or is he losing weight in the last 2 months, I can remove a balloon and insert another. If in the previous month, like the previous last month, he's not losing weight, I remove the balloon and keep the patient without balloon for 1 or 2 months and then insert the balloon again. In this case, the nausea and vomiting that occurred in the first week, it induces weight loss and it helps the patient to start lose weight again.
Okay, and do you think that the Spatz balloon, which is the one approved for 1 year, and has also the facility that you can increase the volume, could be a better option instead of 6 months balloons?
A lot of studies have compared both, either sequential balloons using Orbera and the SPADS balloon. They found no significant difference between both. As regards to the volume, the SPADS balloon, the maximum volume is 700 ml. I actually use also 700 ml in the Orbera balloon. So I cannot increase more than 700 in both balloons.
But you can maintain the duration. You can maintain it until 1 year.
Yeah, but I can insert another balloon for another 6 months.
No, except for the 6 months balloon. You can keep the spots for 1 year.
1 year,
and
yeah.
in some patients, there are studies, and we saw that they said in some study you can obtain high decrease in weight in these patients by increasing the period.
This is true, but as I'm telling you, I can use 2 Orbera balloons. After 6 months, I remove one and then insert another one. So it is 1 year also.
Okay, so you reinsert.
Yeah. If the patient needs more weight to lose, I can insert 2 balloons.
Okay.
Because the SPADS is not approved yet in Egypt, and it has had a lot of...
It's not approved in your country.
And it had a lot of technical difficulties. I used it in the UK before. It's very difficult to insert and remove. I tried the SPADS 2. Now they have the SPADS 3. It's much easier, but still it is...
I use the SPADS, and it's very okay for if you are going and you have it available. It's very good. And what do you think about the price for the endoscopic procedures in this treatment of obesity? Do you think that there is affordable for, I don't know how it's in Egypt.
It's very expensive also.
For this, but I know that the kit for the endoscopic sleeve is very expensive.
Yeah.
Is in Egypt the possibility to be supported by health insurance in some of this treatment?
Up to now, no.
No, so all is on own expense of the patients. Thank you.
You're welcome.